So, good morning, everyone, and a very, very warm welcome to yet another episode of Empower.
Good morning, ma'am.
You can all keep yourself muted. Thank you very much. Because this is a webinar, so we will be inviting our guests soon. I would request our Telangana team also to stay off the video for some time. So let me do my duty of Annie till I invite you people on the video. So thank you very much everyone for joining on time, and we hope that more will be joining. This Empower Hour is envisioned by Association of Nurse Executives India to promote patient safety. Last year, we committed ourselves to learning about the WHO patient safety curriculum. And this year, we are using the incidents or events, patient safety events collected by the education committee of our association. There are 100 cases which have been collected, and we are very happy to inform all of you that all those 100 cases are now with the publisher to publish it as a book, and that is going to be our first publication that will have the safety event, and there will be some discussion around it. So 100 cases for all nurses and nursing students as a gift from the members of Association of Nurse Executives India to promote patient safety. Each one of us cannot make the same mistakes, to learn from our own mistakes. So in healthcare, it is very important that we learn from others' mistakes. And this year, different ANEI chapters have been discussing one case from that book. So you all are welcome to learn from this, and all the Empower Hours that we have conducted so far have been, recorded and available on our YouTube channel. And in December, hopefully, based on those Empower Hours, there will be a mega quiz that will be organized by association as promised by us in the beginning of the year. So just give me a moment. I want to share few information about the association with all of you. The book is also called as Life, Learning Ignited from Errors. And this is the track that we are running this year under. I'm very happy to announce that we had our third annual patient safety webinar this year on September 30. And we had over 3,000 participants. But as a pre-conference, started the training of nursing students on IPS, National Patient Safety Goals. And it is not an event that stopped with our conference. And we have so far trained over 4,000 students, and we are hoping that we should reach 1 lakh students in 1 year. And the response had been great. The trainers are being trained by ANEI, and then those trainers, they go physically to colleges to train the nursing students. So we are hoping to make a small difference to the students so that they are knowledgeable about the IPSGs, and when they come to hospitals they can be safer nurses. So this is the flyer that is created to inform everyone, and the trainers will be trained, and they'll be going out and training more nurses, students, and this is being done under the with the collaboration with the state chapter heads. So if you have any queries, if you are interested, please do let us know. You can write to Annie Treasurer at the rate gmail.com, and the information is on the screen. So you can write to them and understand how can this workshop be held in your premises, because the trainers will come to your college. The college just need to give the logistic support, and there will be pre-test and post-test, and then certificates will also be sent from the central office. So this is an ambitious plan, and we are very happy that it is ongoing. And we are also happy to announce that our ANEI Patient Safety Fellowship Program, which we started in 2021, on 29th of September, the first batch graduated after 2 years, spending 2 years, but some of them are still continue to contribute as mentors. And the the batch two will continue for one more year. They'll mentor, they will do some more activities under the umbrella of any patient safety fellowship. And this is the third cohort that we have inducted this year, and they are just started their journey of the fellowship program, and we hope that they will also make a difference contributing to patient safety. So watch out for the Facebook announcements and membership announcements. And even if you are not a member, please contribute to the Facebook, and then you will come to know what events are happening. So, in the annual patient safety conference, that with the title Towards Zero Harm as our major umbrella, we had adopted the WHO patient safety days theme, elevate the voice of patients. So there were 7 tracks, multidisciplinary speakers, national and international, and we were honored with the presence of Dr. Neelam Digra from WHO and Dr. Michael Ramsey, CEO of the Patient Safety Movement Foundation, with whom we are collaborating on the fellowship program. There were evidence-based practices and quality improvement projects presented, and we had selected winners. There were 3 each, and you can see the hospitals who won the competition. Congratulations to all of you, and they get also prize money from the association. So we, as our association is committed to work towards the betterment of nurses and nursing. So when we become better and we make life safer for our patients, automatically nurses will be recognized and given the due position that they want to have in the healthcare delivery team. Now, it gives me immense pressure to invite this month's team, that is from the Telangana state of ANEI, with President Ms. Sarita Vijayan and Vice President Ms. Camilla and Secretary Ms. Bindu George. Today, Harita is not able to join us because of some personal commitments, and Bindu will be coordinating the deliberations here today. My job is to invite them and tell them a very, very warm welcome. They are the additional speakers from the same state, Ms. Clara, Member Annie, and Dr. Reddy. A special welcome to Dr. Reddy, because we are committed to unsiloing nurses. And because of that, we are very happy to see other disciplines, joining us in our discussions. And Ms. Anuradha Bhatta, all of them are ANI members. So these are some of the things that we do for the members. And in case you are not yet member, please feel free to visit us on our website and you can join. And today's case study is around atracurium, and all the ICU OT nurses will know about this medication as the one that is given for skeletal muscle relaxation, either during surgery or mechanical ventilation. Very common drug. And today's case study is around that. I'm not going to tell you what it is. I will allow the team to do that. So thank you for joining us for this Empower Hour, because it shows that you are committed to patient safety. So thank you for joining, and thank you for those who are joining us from your classrooms, more in number. Thank you for being here. And next month, it will be hosted by Delhi chapter, 25th November. That case is on patient assessment and never miss the basics. So we hope to see every month. And in case you miss it, you can always watch the recordings. That is not a problem at all. But please do that. And you want to give back to nursing, you want to learn from the senior nurse leaders, join us. And all you have to do is visit our website, www.anei.in, and then there is join us. Click the button, you become the member, and then you come to know you can. There will be a lot of other things that is happening for members only. Thank you so much for being here. And now I will hand it over to Miss Bindu and team, may I request all of you to come on the video? And now onwards, I'll be going off audio and video, and I will hand it over to the team. Bindu, a very warm welcome. Please take it over from here. I'll be at the back end. If you need any help, just let me know. Thank you so much and wish you all the best.
Thank you, Ma'am Tankam. Thanking Annie for this great opportunity that is given to Telangana chapter, and thanking all of you audiences for your curiosity to learn and understand and for your presence. The natural human instinct when we commit a mistake is to show it under the carpet or to hide it from others, isn't it? We all know this. But there is a saying, to err is human. So I thought I would add something to that. To err is human, and to learn from the error and to prevent it from occurring in the future is humane. So with this, and every error that is analyzed brings us one more step closer to excellence in our nursing practice. So we have created a video on the situation that is going to be discussed. We shall be playing the video now. After the video is played, we have the expert team from Telangana I will be introducing them, and then they will be discussing on the situation that is discussed on the video.
An 8-year-old male child was brought to the hospital with complaints of breathlessness, cough with expectoration, evaluated diagnosed as acute lower respiratory tract illness, and admitted to PICU for further management and treatment. On evaluation, the child was hemodynamically unstable, found to have respiratory distress where the child was intubated, started on IV antibiotics and supportive care. On day 4, with discussion with the team of consultants, the baby was planned for extubation.
Hello, sister.
Hello, doctor.
Hope there are sufficient staff for the shift.
We are understaffed tonight, sir.
How is the baby? What are the ventilator settings?
Baby is hemodynamically stable, sir, and baby in CPAP.
Baby seems fine. Show me the ABG. Okay, ABG is normal. Arrange all the articles for extubation. Hi, sister. How is the baby after extubation?
The child got extubated at 10 p.m. and was connected to oxygen mask with 6 liters of O2 on flow.
All right, I'll take rest in the doctor's lounge. Call me if there's any emergency.
On the back end of the case scenario in the ICU, the occupancy of the beds were full, and in view of less nurse-patient ratio, even the TL was taking care of 2 patients. The nursing team leader observed the child's deterioration.
Are you okay, baby? Are you okay?
And she immediately administered injection atracurium 3 milligram intravenously, thinking that the child is still intubated. Immediately, the child went into further respiratory distress, and soon on observing that the child is deteriorating, she started resuscitation and advised the nursing team to call the doctor.
Hey, sister. What happened? Oh no, baby's in respiratory arrest. Get the crash card. Give me the blade. Get the tube. Let's intubate the patient immediately.
The PICU doctor arrived, re-intubated the child and settled the scenario. He debriefed the nursing team regarding the scenario.
I hope the video was very clear to all of you. Hope there were no much disturbance. So I would like to now invite the team of our experts here. Let me introduce the team of experts from Telangana. We have Dr. P.J. Praveen Kumar Reddy, who is the Medical Superintendent of Star Hospitals, Hyderabad, and he will be assuming the role of the doctor for analysis. Ms. Pramila, who is the CNO of Star Hospitals, Hyderabad, and she in this analysis is going to assume the role of Chief Nursing Officer. Ms. Clara John, who is the Deputy Nursing Superintendent of KIMS Hospitals, Hyderabad, will be assuming the role of the TL. And Ms. Anuradha Bhatta, who is working at AIG Hospitals, Hyderabad as AGM Nursing, and will be assuming the role of the junior staff nurse. So this panel of members is going to analyze and discuss how this error has happened and how this can be prevented in the future. Over to you, team.
Thank you, Bindu. I think by seeing this video, we could analyze many errors which we can be prevented. First thing that we should appreciate the nurse as though she has committed the mistake. She has accepted and immediately she has alerted all the team members and we could do it immediately, resuscitation and survive the baby. That was a good thing that we can appreciate the nurse. But there are a lot of flaws that where we can correct ourselves. Coming to that, first we could see that there is a understaffing. Nurse-patient ratio was not maintained. Though the PICU was with 14 beds and they have only 3 nurses as they are fully occupied with other patients and there were ventilator cases. So I must ask whether the nurse on duty, did she do escalation? Can I know your role, Clara, what you have done for understaffing? Did you do anything?
Ma'am, we had on that day like 14 patients. Our PIC was full and we had 3 patients on ventilator. And the nurse-patient ratio was 1:3, where 4 nurses and including me 5. And I also, as a team leader, I have to take 2 patients who were on ventilator. And all the we had all critical patients. And the situation like the baby has gone into the respiratory distress, where I want to save the life of the child. So I thought I have to give the injection immediately. So I have administered injection atracurium 3 mg IV, keeping in mind that the patient was still on the ventilator because of the critical situation.
Yeah, but we can observe there, though you have given the injection, I understand that you may be tensed because of the over workload and all. But as it is a high alert medication, we should have taken the doctor prescription. Without the doctor prescription, we are not supposed to authorize to give the medication for the patient, any high alert medication, and we should also have a double check.
That day the doctor was not there and there was no replacement. So the burden was on me and it was a critical situation. So I was just thinking to save the life of the patient.
Yeah, but still we should have been a little cautious so that we will not commit an error, because it's a high alert medication. Atracurium is a high alert medication, and we should also check for the safety of the baby, and we should have at least verbal order, because I understand that there was no doctor availability. We should have doctor to have the order, as the doctor was not available and you have not taken any verbal order and directly you have given, which we were not supposed to do. As a nurses, we are not supposed to do without any verbal order also, any medications which was prescribed. So we need to be cautious where we are giving these high alert medications whenever it is prescribed. And at least we should have any display or standing orders for these high alert medications, how to give with a like a PTC committee approved. It would have been better that in that way nurse would have come down with her burden. And next is, did you escalate any like situation scenario to the higher level, Clara?
Ma'am, like it was full busy and it was fully occupied, and I was also with the 2 patients, so I forgotten that I should have called the night supervisor and I should have asked for the extra help.
Yeah.
I couldn't do that.
Okay. Whenever such scenarios, we as a nurse leaders, we must think about the ground level people, how they are struggling. So if they are not able to, and on-duty supervisor must be alert, doing a repeated rounds, checking the ICUs where it is required, and we should see that the help is always kept aside for them. We should have a standing staff, like a buffer staff we should maintain always, so that wherever it is busy, if we have a skill mix staff buffer, then we will be able to help them in these scenarios. So if they could escalate to the on-duty supervisor, then it would have been better that they will get help. And we had a problem there. The doctor was not available in that situation. And if the doctor would have been available, it would have been better that we would have not had, the nurse would have some help, and she would have not had that scenario where she has to go and give atracurium without the standing order. And the doctor would have replaced with some other doctor if it is possible.
True. I think, see, here, apart from the doctor not in the ICU, the first mistake was from the doctor's end, where the doctor is not in the ICU. But the second thing is, like, when he is left the ICU, he had a very clear communication with the TL saying that if any thing goes wrong with the baby, please give me a call. So that was one point which was missed, and the other thing rightly pointed by Ms. Pramila was like high alert medication should not be given without a doctor's prescription, which is not acceptable actually. But the recognition, see, what went right was the immediate observation by the TL that the patient is going into respiratory distress, and immediately she acted on, started to give medication, and actually. That went well, and the patient got intubated at the right point of time with the help of the duty doctor, who has come back. And second thing was, the doctor patiently explained to the staff what went wrong and what went right, and what are the lessons to be learned at that point of time. So that's from my end, actually.
Yeah, the debriefing which the doctor has done after end of the procedure, which will help us to understand where we are supposed to act immediately, which I feel. I think if anybody of you would like to comment, please, it's open to you, Bindu or Clara, on this. Bindu, can you hear me, Bindu?
Yeah. So what I also felt is that, as you said, the escalation matrix, which needs to be remembered. Sometimes what happens is, when they are under pressure, anybody would crack. So they try to work in a it's not that they try to, they end up in a miscoordinated way of working. And precisely that is what has happened here. The TL's mind here is already preoccupied with the less number of staff and more full PICU, and also patients on ventilator. So criticality of patient condition and the absence of doctor at that moment for some time, and also junior staffs. So there are too many factors contributing to heightening her pressure. That is what we understand here. But despite all these, we have certain golden rules about high alert medications. That is why they are called as high alert medications. So in this situation, probably qualifies for even a verbal order, but which would have, these kind of. So when a patient is extubated, and assuming that patient as still continuing to be on ventilator, this points to the nurse's preoccupied mind. Could be, this would be a result of multiple factors, I'm sure. But it is great of the TL to admit to her mistake and immediately calling for help and getting the patient back. That is great.
And thank you, Bindu, for that. If we could see in this, we have a lot of learnings in this, like we need to have a robust checking system. As we could see in that video that there are a lot of injections loaded and kept. If that with the tension, the TL would have gone to, instead of giving atracurium, if she would have gone to some other drug which may calm, it may lead to death also, it would have been very serious damage to the organization as well as the patient's family is the major damage. So as a staff nurse, what is our role in maintaining the high risk drugs when we are storing at a place? Can I have your words from Anuradha from AAG Hospital?
Yes, ma'am. So as per the JCA standards, now we have a good policy and protocol of storing the drugs, and the multiple trainings of the storing drugs and how to use the emergency drugs and high risks are very, very important. And this will play a really vital role in the day-to-day in our bedside work. So the trainings and the proper guidance for the staff really play an important role, what I think now.
When TL was busy, as a staff nurse, are we helping the TL in helping her cases also? Are we taking a responsibility? Because she has other role than the patient. Though she is a TL, she is handling 2 patients as well as she is helping everyone. So in that scenario, as a staff nurse, what are the things that you could help the TL?
Yes, being a PIC was very busy that night. So we had, I was assigned for 3 patients. So I was since the junior nurse, I was very busy handling my patients. So I didn't notice the situation what TL was facing other side unless she called me for the help. When she called me for the help to call the doctor, then I realized that okay, something is went wrong. The situation is became worsening that side. So I went and immediately called for the doctor. So she would have first, as soon she noticed that the TL, the patient is getting deteriorated, she would have asked for the help. So she initially tried reaching to the patient, trying to, checking the complete monitor. Thereafter, she started calling. So immediately I realized that situation. Since the ratio was actually, they became the problem. So I was busy with my 3 patients.
But Anuradha, I think as I'm assuming that the patient is yours or the TL's.
It was TL patient.
It was TL patient, fine. So if you are actually the concept of the whole scenario was to train the junior nursing staff from the TLs and TLs to be training the complete mechanism. So did you follow that? Did you understand what is going with the patient after TL has called you or when she has for help in the last?
Yes, doctor. I realized that patient went to the respiratory arrest again. So she mentioned that, please call the doctor that patient is arrested. So I immediately understood the situation. Yes.
What is the escalation matrix? What you would have done if that was your patient?
If it is my patient, first I would have asked for the help. First checking the response, then I would have called for help, the TL or whoever is beside me. Then next call will go to the doctor who's actually posted there.
So
post stabilization, maybe I can involve my night supervisors and my superior. But till patient stabilize, I can involve actual people who can actually save the patient.
can you brief the nurse-patient ratio of the complete ICU that?
That was that day we had very busy PICU having 14 patients and only 12 nurses. So one nurse was getting almost 3 patients. So TL got 2 patients with patients were very sick and patients were in ventilator.
So did you ask your TL to escalate this to the supervisors or any help and all these things, or you have just taken the 3 patients on your own?
I was just taking the patient because I was not looking after the responsibility of manpower. Since I'm the junior nurse, I was only took patient what is assigned to me.
But as per your thing, if you are overburdened and all these things, you need to have the voice to raise and ask for help, right?
Yes.
So did you miss that?
Yes, I missed that.
So that is
Because
one
we
more.
were actually not able to, last few days, not able to maintain the proper ratio. And this was going on. That night became very hectic with the ratio.
Yeah. Apart from the concerns, what has happened in the case, you need to have the administrative approach, what went wrong.
Yeah.
So apart from the clinical approach, we need to have a discussion about administrative approach as well. So the administrative approach would be maintaining of the nurse-patient ratio, and even to the TL or yourself or someone who is handling that case. So you need to assess, because the doctor might come and go or whatever happens, but you need to think of whether the patient is extubated early, or early warning signs of respiratory arrest following extubation and all these things, which need to be actually taken care of. That is the learnings from administrative aspects, what you people need to have a clear-cut picture on.
Thank you, Dr. Praveen. That was clear that where all we are missing the points, and a briefing on these points. What all the things that we can learn is here. We should have maintained nurse-patient ratio as per requirement, not overloading the nurses on bedside as well as the TL. And as a nurse leaders, we must have a repeated check on the clinical areas, with the help of the team, nursing admin team. And we should also have repeated sessions on high alert medications, how they have to monitor the high alert medications, and the policy, whether they're following properly or not, we have to check. And we should also make sure, take a help from clinical pharmacists for training the staff upon whatever the doubts that they have on high alert medications, and storage of the drugs, whether appropriately stored as per recommendation, high alert drugs are stored or not. All these things we need to keep it in mind and work on that. That will help us, our nurses, to understand where they have to follow, what instructions to be followed. And whenever the high alert drugs are given, they should follow with the double check and all, so that we can, if Clara would have checked with other nurse, she would have prevented that error. So there we missed out checking, double checking. So we all must educate our nurses that this is the important thing, that whenever we are administering high risk medications, we will, if we follow proper standing orders, we would prevent errors with that. So that is one understanding which we can. And the escalation matrix is more important every step. Not only the staff nurse, TL, every area, the escalation matrix is important in each and every situation. And we should have all asked the doctor that if a doctor is going for rest, we should have asked for some other doctor to be replaced in that ICU, as it is a high alert area, pediatric area. So we need to be very cautious. So we should have asked, doctor, you are going for rest, we need somebody. That where it shows our nursing empowerment. So we should have asked that to replace other doctor for those 2 hours where the doctor is going for rest. Then it would have been helpful for the nurse and the TL over there. So these are the few things which I feel that if we would have overlooked, and we would have prevented error causing harm to the patient, which I feel. Over to you, Bindu.
I hope from our side the discussion seems to have come to nearly an end. If there is anyone from the audience who would like to have further points added, please, you may. Because these are situations that happen, round the clock, anytime, anywhere this can happen. And discussing on these mistakes is a huge point of empowerment for all of us, because gone are the days when, all of us used to just hush about all these errors that happens, or even one unit mistakes wouldn't be even known to the rest of the units in a hospital. So discussing on the mistakes that has happened is a huge beneficial factor for us.
So, thank you, Bindu and team. Great discussion. The video was an eye opener. Me being a critical care nurse, I have witnessed such things happening. So, great discussion. We talked about the business of an ICU. It can happen anywhere where there is a shortage of nurses, and the nurse patient ratio can be not very safe. It can happen in hospital, and it's very easy to say that we need to give the nurses, but it may not happen all the time. Sometimes this is human to human industry. Anything can happen anytime. Maybe you'll start the unit very, very quiet, and suddenly a lot of things can change, all of a sudden. So one need to be prepared. So you did talk about the escalation, the nurse patient ratios. The drug that is in question is a muscle relaxant. It can only be given if there is a respiratory airway protection. We know that because, if patient stops breathing, the patient will arrest. So I'm sure in this case also, I have seen it in my own experience. I've had such events, not that I gave, but I have been a critical care nurse. I had been an administrator, so almost 30 years plus in the hospital. So I have seen these kind of things happening. Some of the things that I noticed, most of the points you have covered. The most important thing, as Bindu and all of you said, is to learn from the mistake. It's very good that the nurse immediately recognized. So there is no problem with the nurse's knowledge, skill, because she's a TL, she knows what is atracurium. And in another hospital, same event happened, but the atracurium came from the nurse's pocket. This is another habit that critical care nurses, they tend to keep the midas and the atracurium in the pocket just in case, little bit here, little bit there, midas, the doctors will also say, give a touch of midas. So we give a touch of midas there, here, and suddenly the midas will become atracurium. Then the hell breaks loose, right? I've had a situation where the intensivist is taking rounds. Patient is extubated. It's a very large ICU. Patient is extubated and put on, mask, and patient is doing okay. They're still on rounds. And the TL also went for rounds. The nurse had two patients, not three, two patients. So she was with another patient. And then this alarm came for assistole. So before that, the patient became respiratory distress. So obviously the nurse thought she is giving midas, but she gave atracurium. She never realized it is atracurium, thinking it is midas, because both were in her pocket. So when the patient became, the gong sound comes for assistole, everybody started running to the patient, and they started, and the doctor who was there, he said, did we do anything? Because the patient was doing okay. Did we do anything? Then she said, I gave midas. So he said, show me the syringe. He's also from critical care, so he also knows mistakes can happen. When she took out, it was atracurium. What I'm trying to say here is there is something called situational awareness. Mistake anybody can do. That's why Bindu told in the beginning, to err is human, and not to learn from the error is a crime. That's what I would say. That's why we are discussing all these things here, so that all of us can be safer. So situational awareness is what I would like to bring here. The real being aware that I am in a situation where I have less nurses. I'm taking care of two patients. So maybe she would try to ask for help. See, this is all learning for us to say, when you know that the situation is very tough. I think Dr. Reddy mentioned that even a staff nurse should be able to escalate, have the voice to say, hello, I don't think that I am safe. Knowing that we are humans, there are two great things about humans. One, it can think critically in any situation. not like a computer. Computer will go by algorithm. If you go like this, go like that. But then humans can think differently in different situation. So that is a plus point. But on the other side, the humans can also get distracted. They can get caught in the routineness of work. The routineness of work, that means when somebody is, restless, patient on ventilator, you give atracurium. Maybe that is the standing order there. There is a possibility. So without thinking that the child has been just recently extubated, I should not give atracurium. So maybe she was because of the business. So my suggestion here for individuals to know that I am in a situation where I can make a mistake. That awareness is more important, because we cannot guarantee that such situation will never happen. It is not possible. In any hospital, it can happen with best of intention. So maybe the staff nurse will escalate that I need help. The TL will escalate, while you are trying to manage the situation, you will escalate and say, I need help, because these are unsafe ratios. These are called unsafe ratios. There is no point in burdening a nurse with more than what she can manage, even if they are experienced. So here, though the nurse was experienced, the mistake happened, not that she intentionally did it. She's distracted by many other things which are going around. So by mistake, it happened, right? The root cause analysis was done well, but I would always suggest, in 1 hour, Empower Hour is not able to do a complete RCA. So when we sit down, the human factors is very important to consider. What were the human factors involved here, apart from the ratio itself? And when you come to think about what can be fixed, there are three things that you look at, especially the structure, the resources that you have, that, whether I have the right things in place. So important when we do that, the human factors is to see that how can we reduce the chance of a human being, that means nurses and doctors, making a mistake, even by mistake. So you saw the tray, that multiple trays, in one tray, multiple drugs were kept, though they were labeled, right? So maybe need to look into a protocol to see that as soon as the patient is, extubated, should we be even keeping such syringes in a tray is the question. So there should not be, we should not keep the drugs which can actually lead to fatal mistakes. We should not be, even keeping them for easy access, right? So when I went to Taiwan, I was on a recent visit to Taiwan. So there, I had seen that they had, special dot stickers, on all kinds of, syringe pumps and syringes everywhere. They had put this high alert stickers. So they had put even on a prepared syringe also that the sticker was there, but they were following barcode. Everywhere there was barcode. So in an emergency, the nurse may fail to scan the barcode, right? Like you said, you may not be waiting for a written order all the time. In ICUs, it can happen that, if a patient is very restless and patient is on ventilator, you may be allowed to give atracurium, a top-up dose, because it is covered in the standing order. You can give sedation, you can give muscle. These are for critical care nurses, not for anybody else. If it is there, because if it is not there, then you are in trouble also, because the patient will be suffering for too long. The doctor may be not there for some time. Either they went to rest or they went to the washroom. Anything change in a second. So critical care nurses are empowered through standing orders to do X, Y, Z. So we need to also think what are those engineering controls that we can put in place so that the nurses will not make mistake by mistake. So when you look at, doing a kappa, it's not about just telling people and training people. And here the reason is not because the TL was not trained enough. Of course, she was trained enough. She knew what is atracurium, right? She knew the action of the drug. It is just that because the unit was too busy, she just forgot that the patient was just extubated. It was to err is human. It was a classical example to err is human. Now, how do we make this human be aware? I can only tell from my own experience, one need to tell oneself all the time, hello, I am very busy today, too many things on my plate, so I am going to be extra alert. And there is one more thing I will give to all the nurses, all the students, whoever is here, whoever is going to watch this. Never ever forget to self double check. It has to be like a diktat to yourself. I have worked in critical care for 16 years. And I remember the two mild mistakes that I did. And I know in both situations, it happened because I did not do my self-check. They were not high alert medication. Regular medication, digoxin and Lasix. They did not need. In both cases, I underdosed the patient. I did inform, I escalated, I did everything. But something I learned from my life is that I will always self-check before I do something. I just wanted to add this to your discussion, which went extremely well, but it's very important for all of us to take away what is it that I can do. Most important, ask for help. As Dr. Reddy said, it doesn't matter whether you are a young nurse or you are a TL or you are a supervisor. When you know the patient care is under threat, please speak up. It's very, very important to speak up and say that, hello. We have to learn to say, don't cry and say, hello, madam, I have 14 patients, I have only these many nurses. That is not professional. You should be able to say, I have 14 patients, I have this many patients on ventilator, I have this many nurses, and ventilator ready nurses are so many. So I am afraid that my staffing is unsafe. I can do my best, but I would need help. You make such a call to a nurse leader. In India, we are not used to this because I had been at the receiving end. So when I get a call, it's always crying, Madam, I said, come on, yeah, tell me the exact situation. We have to learn to all the TLs and ward in charges and supervisors, we have to learn how to speak up for what you need to deliver safe care to the patients. No hospital will be there without protocol for high-level medications and labeling, Tolman lettering for LASA. All these things are in place. Despite that, mistakes happen. So I'm so honored that every single time the chapters they come, they are discussing various events. They don't even know. No one knows where this happened. These are all collected from almost 50 contributors. All ANEI members have contributed this excellent collection. Whenever the book is released, I'm hoping that all of us will buy a copy, use that to learn from others. So this is my take. I really wanted to give that piece of situational awareness. Any one of us can get caught in something. It's very important to tell yourself. It's almost like when I land very late night in the airport or in the railway station, I tell myself, it's very late. I need to be careful. So when I get into the cab, I have to send a message to my son that I am in this cab. So we all take care of that. So we just have to practice being aware of where we are, what is happening, and telling ourselves there is going to be a risk of something that is going wrong. So thank you so much. I added that to the team's discussion. And if anybody else has got anything to share, please do that. I can see, I think Ajita, our national president of ANEI is here. Ajita, would you like to come on and add something? Thank you for taking time for that.
Thank you. Congratulations, Telangana team. Today I could attend your session, and it was done very nicely. Thank you, all the organizers. You could get the crux of it, and yes, these things do happen, as Tangam said, in every other day in our ICUs. But many a times, probably we don't talk about it, or we somehow hush it up, or we'll punish the end person who happened to be unfortunately there at the receiving end, or who ended up doing it. So I wish such discussions happen, more often. And though we all are like you all are the discussion people all are from reasonably good hospitals or very good hospitals, and we are under the notion that every ICU this is the way things happen, and actually it is not. So most of our ICUs in this country are still yet to hear about NABH or JCI. Okay, so and also about the quality. So this is not the reality what we all are discussing. I feel is we are discussing in a very privileged setup and to the privileged people. But who will be listening this later because this is going to be uploaded in our website. And I am sure these kind of things are not there in many of the ICUs. So we should be able to have more discussions, participate them. I was just looking at the numbers, so I wish more people from level 2 and level 3 and even smaller towns. They do have smaller ICUs there too, right? Even level 2 NICUs are there in many places. So and atracurium and all other muscle relaxants, high risk drugs are kept everywhere. At least in accredited hospitals, it is kept under lock and key, but not really so. I mean, I still see a lot of NABH accredited hospitals, all these drugs are there around. So when you walk around in the wards, you can pick it up yourself. That means anybody can pick it up, right? So it is not kept under lock and key. And so one thing what we can do to the nurses, to every healthcare professional, probably who handles the drugs, is to have that distancing or keeping it safe, especially the muscle relaxants, because we unknowingly, if we give the drug and realize it was a muscle relaxant given, time will be too late for saving the patient. So something which every nurse should be alerted is about these muscle relaxants. Unless there is a prescription and unless there is a reason, we should not even be able to access it. So preventing access is what is most important in this. And one point which is not related to really patient safety but staff safety is that muscle relaxant is one drug which is very commonly used for suicide among the healthcare professionals. I have lost around 7-8 close people, my students, colleagues, staff, that in depression they'll flick it and use it for killing themselves, and it's a very, very dangerous drug. So we should be aware of it, that there is a possibility like this, and utmost caution and care should be implemented when we deal with muscle relaxants. And it should not reach to anybody without having a second check. That is why we keep it under lock and key. But many a times we bypass this and we cut short the protocol steps, and that is what ends up in situations where we unintendedly give this drug, and it will end up in calamity. So muscle relaxants are one group of drugs which we should take at most caution. Probably out of all drugs, this is one drug which we have to be very, very careful about, and it is our duty to teach every nurse. I mean, why don't we teach in our induction itself? And the repeated listening or repetition is required for for people to reinforce this learning. Because once we say casually, because even in induction, a lot of things are taught to them. 1,000 things are taught together. How much somebody can absorb and understand it? So probably every in-charge team leader in their daily talk, if we include these points, it will register in their mind. So that it will become a habit to take care of these drugs, and not so that your eyes will go wherever it is lying around. So that is what the behavior change we should bring about in relation to muscle relaxants. Thank you.
Thank you, Ajita. Any more reflections from the team, Telangana team? Anything more after you hear? I'm so surprised that Ajita has got so many people committing suicide using the muscle relaxants. I know of one case when I was working in Middle East, where morphine and plus this, So I think high alert medications overall, they are pretty dangerous. That's why they are called as high alert. So there are some safety protocols that cannot be, overlooked. And this is really something that we should. And we know that in critical care, these are being used and sometimes they are kept aside just in case you need to top up something. If I understand correctly, nowadays, most of the hospitals are into infusions, not on boluses, correct? The atracurium and midazolam are going only as infusions, so not as boluses. So it is worthwhile to check whether you really need to have any of these medications at the bedside. Is it really required even? Because why not just give the infusion and you can increase the infusion rate? In this case, if the atracurium was not at the bedside, the nurse would not have been able to administer, correct? And if the infusion was kept there at the bedside, if she wanted to reconnect it, she will have time to think, what am I doing? Correct? So most of the time, mistakes happen not because someone wants to do it, it just happened by a mistake. The same case as somebody connecting the TPN to the central line. The patient obviously died. So what is the solution? The solution, engineering control, was to make the connections not possible to be connected. That's an engineering control where the TPN sets the nozzle. You cannot connect it to the central line even if somebody wants to connect it. So this is the way that, the world is thinking. This is called the engineering control. If you look at the, RCA for any event, what all things can you do? What is more effective? Training and education is right at the bottom because they are not the solution to prevent such things from happening. So right on top, you will see whether you can eliminate. That eliminate means in Hindi, na rahegi baas to na bajegi basuri. That means if the injection is not at the bedside, the nurse will not give it. So we need to think of a process or a change where you can just not allow that to be there at the bedside. Not always. And each case will need to be discussed separately. So these are case studies where, the TPN connection, and this all came from nurses who said that we need connections which will not fit even if the nurse wants to connect. That means it will not connect. So she will ask somebody, why it is not connected. So maybe we all should think of such processes which should make our life, our life of more safer practices, so our patient care becomes safer. Last round of your last thoughts from each one of you. We'll start with Dr. Reddy.
From my end, I only wanted to tell one thing, that the education program given to be given to the nursing, rather than the like the heads or whoever will teach. That's what I have learned. But whoever will teach should give the responsibility to the junior staff to train the teammates. Because what I observe generally, the questionnaire changes if it is a colleague. The questionnaire changes if it is a boss. And when a boss teaches, I know the knowledge will be different, but when the boss teaches, the students or the nursing team or whoever listens to it will not actively think of asking questions or something like that. So it's only one-way communication. If you train the junior staff to tell what to tell to the other people, I think the better communication and to get it reach to the deeper places of the heart or something like that. So which might help in such kind of scenarios, in if you are trying to tell about high alert medications, policies, SOPs especially. So every hospital runs through like by an SOP. The SOPs, if we train through these staff or the juniors or so, they will also get committed. They'll have this understanding that, okay, my boss make me responsible for one thing, and other people also have this challenge to accept and they'll also come into that scenario of learning actually, rather than getting into an Aphrodite mode or something like that.
Totally, it's a brilliant idea, and this is a suggestion. Even in colleges and schools, this is called peer learning.
Yeah.
You allow, and I think that's a brilliant idea. Anybody can take away. You take one SOP, give to one nurse, and tell her to teach others. Give something else to someone, and also there is something called I used to call it as positive discipline. So what happens when someone gets involved in some kind of a thing? My disciplinary action was not taking any punitive. I only tell them to go and train. I will say that you have this many nurses, so you take 10 days, train all of your nurses. After that, I will just come and check whether they know it or not. So that way the nurse involved learns, and then she teaches more. And I think you explained this very brilliantly. Yes, when seniors are training, people keep quiet, and they may pretend to listen, but maybe nothing will go inside. They have certain concerns, they will not speak up. All this can happen. So very good idea. Thanks, Dr. Reddy. Anyone else? Pramila, Clara?
I just would like to add for this, what we have implemented here is, recently when a nurse committed mistake, rather than punishing her, we asked her to take 3 sessions covering entire staff, so that it will not be like punishing for her. It is a learning for her, which we made as per SAR's idea. So we have done this and we worked out. Then the staff felt happy that she was given a role that she will be training Volke. Then she was happy, and we had a good feedback on that.
Good. Great. Clara?
Ma'am, simulation-based training must be initiated with such an errors so that the nurses understand better. And I think the monotonous training in the classroom, it is no longer a better impact.
Perfectly said. And it is true also. That's what Bindu had shown the video. That's actually a simulated scenario. So you don't need video, you don't need anything. So what this is again a concept in simulation based learning. It is, they call it as a roving patient. So roving patient means the education team goes to the ward and they enact this happening. So that video was about 3 minutes and 41 seconds. Okay. So if you do that as a role play till the error happened, not beyond that. If you show this as a role play and ask the team in the ward itself, okay, this is what happened. Why do you think that it happened? How can we prevent this? They are the ones who are going to tell. We should do this, we can do this, we can do this, we can do this. It has got more power than making them sit in a class and then listen to lecture, PPT lecture for half an hour, 45 minutes. So perfectly said. And simulation-based learning has got more retention. They will remember because there is always a simulation. They experienced it. They saw it. So they will remember more. And more learning, if it becomes simulation based learning, the effectiveness is going to last for longer time. And please don't mistake, for every simulation you need a mannequin and monitor, and it is not necessary. You just need a little bit of creativity. You can run this in a very basic thing with some props, etc. And great point. Thank you so much. And Anuradha, you have something to share? Then I will go on to Bindu before we wrap up. Yeah. You are muted. Anuradha, unmute yourself, please. Yeah.
Ma'am, as you rightly said about preloading of medication, that practice actually better to avoid and make sure that our nurses are not practicing that. Only at the time of accreditations and audits we see that everything is going smooth, but the practice again come back. So preloading of medication, storing of the drugs, and that can be trained to the junior nurses and to all the team people. And in this scenario, ma'am, if you look at the extubation of the patient in that situation, like busy hours and having a busy situation in the PICO, was it suggestible to do right that time? I was actually thinking.
That's a good question to ask, that should we have the practice of extubating patients when the ICU is on fire. I don't know. Yes, maybe that is one way. That is called a process evaluation. The
Yes,
process
yes.
of extubating. It's like when I was in Fortis, we had this practice that all ICU patients, if they need to be transferred, they should be transferred before 8 p.m. After 8 p.m., no transfers, because we found any patients who are transferred after the 8 p.m. unholy hours, I call it unholy hours, something used to go wrong with those patients, and we said, no, we cannot be go on talking to the nurses. It's not their fault. The timing, people are not there, there are many factors, many human factors. So we talked to the intensivists, we took a protocol that no ICU patients will be transferred after 8 p.m. and there are no ICU transfers at the time of handover.
And
These are some process decisions we took, that every time handover time, when a patient comes in, half handover happens. It is not their fault, because somebody is giving, somebody is going, so in between something happens, and immediately after that something goes wrong with the patient. So great thoughts. I mean, all these things can be considered, and that's why I said, when you sit for a RCA, you have to block minimum 2 hours and write down all the thoughts. That's how you do an RCA. Don't restrict yourself and say all these thoughts, why can't this be? Why can't that be? Why can't this be? Why can't this be? Put everything down there and then see, as an organization, what is it that you can implement. The training should happen, but that should not be the one focus area. You should not start talking about less train, less train, less train, because I know that, all of us, especially the CNOs, we all are guilty of, anything that happens. Nurse educator, come here, make sure everybody is trained. And then we think, oh, my problem is solved. It never gets solved, my dear friends. So it is very important. I know the CNOs are sitting here. I was also a CNO at some point of time, right? I learned it does not work. And also the training, when it becomes monotonous, nothing happens. I can give you this guarantee. When the learners are not engaged, they come and sit because you put it on their head. 1 hour CNE, come and sit here. They all will come and sit without learning. So then you'll say, what happens to all these trainings we do? Nothing happens. So something we need to think, how we train. Process, very good. Good thought. Bindu.
one more thing, ma'am, and the documentation for when we are taking, actually, we are not supposed to allow verbal orders, especially on this medication. So this would have been still prevented instead of the nurse taking a step and pushing this medicine. Should have still wait for the doctors to call and give a orders. Still, if the doctor presence was really needed in this situation, what I feel, ma'am.
I totally agree. But in
Documentation.
in real life, this is what can happen. The
Yes.
doctor just went to he just said, I'm there, call me. But the TL is, of course, an experienced nurse.
Yes.
So they have this habit of giving atracurium on a ventilated patient when they become restless.
Yes.
That's why today you don't see bolus, you see infusions, So starting infusion again would have given her that few seconds to think, am I doing the right thing? So that is why, all these things can be definitely told, but then this mistakes can still happen. That's why we need to discuss such events. So we all become aware that, when I'm busy, I should not have the syringes loaded and kept, so all this awareness probably will lead to more safe practices. In an emergency, sometimes you can't wait for the doctor. If the patient arrest even on ventilator, if the patient is very, very restless, obviously you need to do something. And usually there are standing orders available, whether you give a dose of midas when I was working, but now it could be different. So look at your standing orders. See that whether it is safe for nurses to execute as leaders, as nurse leaders. Is it safe to execute? Are they capable of executing those, standing on? It's like giving sugar for a hypoglycemic patient. If that time, if they wait to inform the doctor, then I will definitely get angry with the nurses. Why didn't you do the first step before calling the doctor, right? So we need to look at each standing order separately and see that how safe it is and who should be carrying it out. Here, the role that is played was by the TL herself. So you will see more such events in that collection where TL is little bit absent-minded because of too many things happening. So we need to train our team leaders and in charges that how to be conscious when you become too busy. When things are quiet, very quiet, also there is a problem. When things are too much, also there is a problem. So they need to know that all these things can happen in their life, and how they need to be extra cautious when such situations happen. How to call for help. So we can tell that it should not be done, it must not be done, but we know in the ICU, a lot of things happen, and it's not always the doctor is standing there to give the order. He can be busy with another patient also. So that's my take on that, to say that let's learn to be more aware of what we are doing, and then remove the protocols which are very unsafe, like keeping a syringe at the bedside loaded with atrocurium and many other medication. We should not do that. So that practice needs to be looked into. Great point, all of you. Thank you so much. Bindu.
Ma'am, there is one thing that I thought is, in this kind of situations where so many patients and less number of nurses, and if it is a constant phenomena, then these nurses definitely undergo burnout. And they are constantly exposed to the stressful situations day in and day out. So maybe it's time, that is one point for the organization and the senior nursing leadership to take up, how to unwind them, this lot of nurses whom we depend heavily on. Basically, the senior nurses on whom we throw the major responsibilities of training the nurses, of seeing the department disciplined and going on well, patients' care, everything is entrusted onto them. So perhaps this is going with an added pressure on them and can actually cause burnout in most of the senior nurses, because junior nurses tend to exit the hospitals very soon and they find greener pastures and move out of the country or somewhere else. So these nurses who are stuck or continuing in a place, them are we trusting more with responsibility. So it can naturally lead to burnout. Probably the chief nursing officers and the hospital management must have a certain program to unwind these nurses at regular intervals, I feel.
No, I think absolutely it's a brilliant point. Being aware of what your nurses are actually going through. It is very, very important. And even mid-level nurse leaders also should think that, I am burned out, it's very important I was the recipient of a kind nursing director when I was the ICU in charge in Saudi. I had a Canadian nursing director where our unit was too busy, and she could see that. So one day she called me and she asked me to come to the office, and she said, you must come. I don't care what you do. She gave me a cup of coffee, took me for walk. Then she told me, I don't want to see you for 2 days. I said, you don't want to see me? ICU is busy. She said, nothing will happen to your ICU. 2 days, I don't want to see your face. And don't make any calls to the ICU. Hand it over to this person and disappear for 2 days. I mean, those it was kind of a mandatory order. I really loved. And I said, oh, she understands that, I'm going through a tough time. And if we can do that kind of actions, empathetic leadership, it can go a long way, not wrong way, long way, that we are being empathetic to us. That's a brilliant point. So it is 12:14, ladies and gentlemen. Thank you so much, and brilliant discussion. A lot of new points also came up later. Each one of you gave absolutely practical points. This is getting recorded. All my friends who are here, you can tell others to come and watch the recording. By Monday, we should be uploading this on our ANEI YouTube channel. So it is permanently getting recorded. All the suggestions, all the good points, all the thoughts that you all brought in. Thank you so much. And we will meet you all again in December for one more case study around patient assessment. Never miss the basics. So you can see sometimes basics, sometimes critical care. And we have only touched about 11 case studies. 100 case studies are there in the book. And I hope when it gets released, each one of us will pick up a copy. And it's a pride, very, very pride moment for all of us when it gets released. It's almost in the last stages. Thank you so much, Telangana team. Great. Well done. And thank you and have a great weekend. Thank you so much, everyone. Take care.
Thank you.
Bye-bye.
Thank you, ma'am.
Thank you,
Thank
ma'am.
you. Thank you all.
Thank you.